extremely broad question, and that's what are common types of arthritis?
Yeah, if you ask about how many types, there are so many. They'll say there are more than close to 100. But among the most common ones, more than 90 of these, 90% of arthritic conditions will be included in rheumatoid arthritis, osteoarthritis, psoriatic arthritis, gout, ankylosing spondylitis. These five will cover about almost 90, and there are always rarer forms like pseudo gout, um, conditions like Crohn's disease or ulcerative colitis related arthritis, reactive arthritis. You'll hear various names, but those are clearly very rare diseases compared to these five I talked about. And among them, rheumatoid arthritis is the most common one.
That's doctalklive.com. Also, watch more episodes of the show on platforms like Spotify, iTunes, and iHeartRadio. My name is Dr. Vic Prakash, and I'm hosting today's show. So, nearly 1 in 4 adults in the U.S. have been diagnosed with arthritis or another rheumatic condition. According to the CDC, this number is predicted to rise, and by 2040, almost 78 million U.S. adults could be diagnosed with rheumatic disease. So, joining us today will be Dr. Joseph to discuss the topic common rheumatic diseases. Dr. Joseph, welcome to Doc Talk Live. Thank you so much for volunteering your time to be a part of our show, and please tell our listeners a little bit about yourself.
Okay. Thank you, first of all, for inviting me to be a guest on this show to talk about arthritis related problems. My name John M. Joseph. I'm a practicing rheumatologist in private practice in Carrollton, Texas, and I've been in practice for almost 40 years. And I was just thinking about this today. I came in June of last year, like they say in Texas. You know, I came to. I was not born in Texas, but I came to Texas as fast as I could. That's probably applies here. So anyway, I've been in practice for the last 37 years in the same location in Carrollton, Texas, and I have 5 kids. They're all grown now, so nobody is at home. And I've something that I wanted to share with you today about the nonprofit clinic that we started in 2003 for people without insurance, and now we see patients who are also uninsured, but underinsured. So uninsured patients and underinsured patients are also allowed to come to these clinics, and there are 3 locations. This is the first one we opened in Louisville, the other one in Plano, and the third and the most recently opened one is in Dallas. And we see patients 6 days a week, and there is a fee at $50 per office visit, and the blood tests, x-rays, and other procedures are all discounted heavily. So I think it's making access to care more affordable, so that patients who are worried about heavy or high medical bills, they can at least know upfront approximately what it would cost them to get their care. So I really want people to know about it. It's called Primary Care Clinic of North Texas. We have a website, primarycareclinic.org. You can look at our services we provide and the addresses and the locations. And there is nothing to qualify to come to these clinics. You don't have to be at a certain show any economic hardship or county residence where you live, or immigration status, or anything whatsoever. Or being insured or uninsured, we don't ask any questions. No questions asked. So at least you qualify to come in without any concerns.
That's
so to
wonderful.
the extent that we can provide primary care and also rheumatology care at the same price.
That's great. I think $50 a visit is beautiful, and that's very affordable for a lot of people. And for anyone who's worried about having to see a doctor for costs, then this is a good avenue for people to access their medical care. So thank you for sharing that. We appreciate that. So Dr. Joseph, I'm going to start off with an extremely broad question, and that's what are common types of arthritis?
Yeah, if you ask about how many types, there are so many. They'll say there are more than close to 100. But among the most common ones, more than 90 of these, 90% of arthritic conditions will be included in rheumatoid arthritis, osteoarthritis, psoriatic arthritis, gout, ankylosing spondylitis. These five will cover about almost 90, and there are always rarer forms like pseudo gout, um, conditions like Crohn's disease or ulcerative colitis related arthritis, reactive arthritis. You'll hear various names, but those are clearly very rare diseases compared to these five I talked about. And among them, rheumatoid arthritis is the most common one.
Okay. Okay. How are most common rheumatic diseases diagnosed? Are these scans, blood tests? How do you diagnose them?
Yeah, I think this is the most important thing that people have to realize. It's really clinical. The diagnosis of most forms of rheumatoid arthritis is by good history, listening to the patient, and examination. Because tests sometimes mislead us, they may be positive without the disease. So there are patients who will get their blood tested for lupus. It comes positive, and then they are surprised. Hey, why is my test positive? They don't have the disease. So diseases are not rheumatic diseases are diagnosed primarily by good history and physical exam. So it's a clinical diagnosis for the most part. Tests help confirm the diagnosis, but it is really not the mainstay of how we make the diagnosis. So it's important to have the suspicion of the diagnosis of whatever it is, rheumatoid or ankylosing spondylitis, and then additional tests will only confirm the diagnosis. And then we'd start considering the treatment for it.
I think that's an important point. All our listeners should know is that clinical diagnoses or symptoms matter, and tests support that. To that effect, I think a lot of the autoimmune diseases, the testing is not perfect, and I shy away from testing unless someone complains to me about a symptom. Because if you test someone who's normal, all it does is create anxiety that they may have a disease that they really don't. So it's important sometimes not to overturn too many rocks, because you'll find something and it may be nothing, but it's going to create more cost and anxiety.
And more anxiety, that's true.
Yeah. So how is rheumatoid arthritis different from osteoarthritis?
There is a big difference, in many aspects. First of all, the age. You rarely get osteoarthritis at a young age. So that itself is a big reason to suspect osteoarthritis in an older person. And a younger person, if he or she gets arthritis, it's likely to be inflammatory arthritis. So rheumatoid arthritis is driven by inflammation. Some people call it an autoimmune disease, but it is certainly not something related to age necessarily. And you can get rheumatoid arthritis at any age, right? And then osteoarthritis often is brought on by trauma to the joint. So if you're someone who is heavily into contact sports, playing football, you could mess up your knees and you develop wear and tear arthritis of the knees. The knees wear out a little earlier than one normally gets this arthritis in your 60s or 70s, but you'll get it much earlier. So wear and tear arthritis is osteoarthritis. So it could be affecting the finger joints. That could happen at an earlier age too, but that's still around 35, 40, 45-year age group who will get it in their hands, involving the small joints of the fingers, the end joints and the middle joints of the finger. That's often called sometimes familial arthritis, and somebody will say, look, I don't want my hands to look like my mother's. And how can you stop that from happening? Unfortunately, there's not a whole lot you can do other than controlling pain. Unlike rheumatoid arthritis, where if you don't treat it, is a rapidly progressive disease in most patients and can lead to deformity. So it's inflammation driven. The other one is really more mechanical and wear and tear driven and age related. It is almost like old age and osteoarthritis sort of go together in general, but rheumatoid at any age, even children can get rheumatoid arthritis. So there is a big difference, and there are several drugs that you can use for rheumatoid arthritis, and the main treatment for osteoarthritis is controlling pain. That's about all we can do today. And in extreme situations where there is not a control of pain or mobility issues, one can only get relief by doing joint replacement. So that's where knee replacements, shoulder replacements, hip replacements, and such come, to help the patient live through that pain of osteoarthritis.
Okay. What's your experience with like physical therapy, weight loss? Do those things help with
Definitely,
osteo?
yes. Osteoarthritis is helped significantly, especially osteoarthritis of the knees and to some extent the hip. Maybe even people with low back pain. Again, we didn't talk about back pain and neck pain, and a lot of times it is related to bone spurs, disc disease. It's a form of osteoarthritis if we can consider, again, spinal joints are all involved in some ways, and the structure of that joint or the spinal joint or the disc joint is damaged, deranged in osteoarthritis. And weight loss absolutely helps, because even 10-pound weight loss, according to Arthritis Foundation, amongst with the studies that they have done, has shown that a 10-pound weight loss reduces the amount of forces going through one knee when you're walking. When you shift weight from one foot to the other, you decrease the force by about 4 times. So 40-pound loss or decrease in the forces going through that knee when you shift from one foot to the other as you walk. So that's felt. Even 10-pound weight loss can be felt as a decrease in pain and discomfort when you do that little. So I don't think you have to lose 40, 50 pounds, because that's a tall order. So it is definitely of some help, or serious help.
That's a good factor worth repeating. So almost a 4x on the weight loss in its effect on force on your joint. That's really...
And quadricep strengthening exercises, which people do it in their gym, or you can put a 2-pound ankle weight. You can get those ankle weights with Velcro straps and then tie to your ankle, and you can do those leg lifts and strengthen the quadriceps. That's again another simple exercise to improve the strength of or the stability of the knee. That in itself reduces the pain. And not only that, it also allows the person to improve the strength of the knee and getting up from a lower seat. I don't know if you've seen people with osteoarthritis, they sit at a higher level so that they can get off the seat easily. So lower seat or sitting on the floor is impossible for people with osteoarthritis in knees, because of pain and also because of weak muscles. So strengthening the knee muscles will stabilize the knee and reduce the wear and tear in the knee joint. So progression to a point where one has to get the knee replacement can be delayed by proper treatment, physical therapy, heat, ice packs, pain medications, and walking. Walking is always good. You're not going to wear out the knee by walking. In fact, that's helpful in keeping the nutrition to the cartilage that is left over. I'm sure there is decrease in the thickness of the cartilage as it progresses, but it definitely has a lot to do with improving the quality of life for a person with osteoarthritis.
Very good, very good. So now with rheumatoid arthritis, since it is inflammatory, it can rapidly progress. Tell us a little bit about the treatments.
We just go over the symptoms first, because
Sure.
I know it's a very painful condition, and I think there is a reason to not misunderstand or take people with rheumatoid arthritis lightly, and it applies to all of us as doctors, and also for people who are patients know how badly they hurt, but it is easy to dismiss the pain by family members and usually the spouse. And a lot of times it is a woman's disease, and I think it is a little hard to understand that it affects the whole body. It affects the mind even, because it's chronic 24-hour pain, and the stiffness and the flu-like sensation that it brings on because of the inflammation causes a whole lot more than just what the joints are doing. So the joints hurt, they get swollen, there is stiffness, you wake up in the morning, you cannot even move. So it's a very profound pain. It's very hard. I mean, I know I don't have rheumatoid, I don't think I can feel it, but patients sometimes come and tell me, doctor, I just want you to know, take this disease seriously, because do not dismiss me. I mean, it's something that has to be understood by everyone, the family members included, because it is very hard to do anything. A simple task becomes very difficult for somebody who has a rheumatoid arthritis. So I think treatment becomes extremely critical. And in the past, when I did my fellowship in 1981 through 84, I was at Southwestern, and we were using gold injections. We had a gold clinic. And we were using drugs like penicillamine. I don't know if they ever use it anymore. sulfasalazine, and hydroxychloroquine. Sometime in 1986, we started using methotrexate, 85, 86, and it became very popular. And that has revolutionized treatment. Even a very simple drug, we now call it very simple because it is cheap, safe, and a good 60% of patients will achieve what we call remission, that is freedom from pain, swelling, and stiffness of joints for a long time. You don't get even resistance to that. Most patients who do well stay well for 25 years, 30 years. I have patients who have taken only methotrexate and they have done extremely well. And it is a very safe drug, so I don't think just because it is considered a form of chemotherapy, in small doses that we use in rheumatoid arthritis, it works wonders. And it is cheap, affordable, and extremely useful drug for us. And then there is another drug that is what we call part of a traditional disease modifying agent. It's called leflunomide. We use that. Sometimes we combine the two drugs, and it can be a very helpful thing. Beyond those two important drugs in the traditional drugs, right, we have newer drugs we call biologics. So many of these are monoclonal antibodies. They target a very specific chemical in the body or a cell even, and we bring about remission. So I think today the expectation for a person with diagnosed with rheumatoid arthritis is almost complete freedom from pain and restoration of normal activity if they choose to get their treatment early. So once the joints are damaged, once they get eroded, once the bone is eaten away and the joint becomes fused, we can't undo that damage. So it's extremely important to seek early treatment and not go with sort of unproven remedies, including steroids in doses that sometimes are given, and it leads to a lot more harm in the long term. Short term, you can sense that improvement that makes you feel like you're really winning the, you're overcoming the disability and discomfort. But over a period of time, I think one will gain weight, the bones develop, osteoporosis, weakness of the bone, and increased risk of infection. So I think there is in the community a certain feeling that, you know what, let me take steroids, I'll do well. But it's a short-term thing. And I know there are people who go to even Mexico to get drugs, and they get infusions of high doses of steroids. You've heard of that. It is a very dangerous thing, and it often causes serious infections and sepsis. We've had a few patients like that who were getting dexamethasone, betamethasone, which is sold not through regular pharmacies, and there are people who get access to these drugs, and short term they feel better, but I think they hurt themselves seriously. So all of these biologic drugs, you may have heard of Enbrel, Humira, Remicade, Symphony, Orencia, Renvoc is a new drug that they're advertising. All of these drugs with different mechanisms of action have extremely been useful to control. In some way or the other, they will work. I mean, I really think there are patients who don't respond to one drug, can be switched to another drug. So I think the expectation on the part of the patients, and I think the confidence of us as physicians dealing with rheumatoid, it's a lot higher than what it was in the 80s and 90s and 2000. We have many more drugs. And if one mechanism of action does not work, we switch to a different mode of action for a different drug that might work. So it is definitely something that you wouldn't give up. And if treated aggressively, you have to be a little brave to take these drugs. You can't just be saying no or denying these drugs. These drugs are extremely useful, and for the most part they are safe. There are side effects, and when you hear about the long list of side effects on the advertisement, I don't think it should be a turn off, because if you look at any drug, there are side effects. But the disease itself is so disabling, untreated. It is important to at least get the proper treatment to control the disease so that you can live a normal life. So I think the expectation is very high for both the patients and the doctors to get back to normal.
That's great. So what I'm hearing is this is a treatable disease, but it is
Highly.
time sensitive. So don't let it destroy the joint before you seek treatment. Catch it early to prevent permanent joint damage.
That's right.
And really restore normal life again.
Absolutely.
That's wonderful. And I can tell you, as a kidney specialist and in my battle against patients overusing NSAIDs, nonsteroidal anti-inflammatory drugs like ibuprofen, Motrin, Advil, common drugs that we all use for pain, and certainly in rheumatoid can cause some relief of pain, but the side effects from chronic use of these drugs can be tremendous, and going on a biologic that's going to prevent this sort of harm can do a lot of good. So I'm curious, can you tell me a little bit about the delivery method for the different options, methotrexate versus a biologic, oral, IV, what are the options there?
Methotrexate is in the form of tablets and also in the form of injection. You can self-inject methotrexate for those people who have, those persons who are bothered by nausea, especially for nausea brought on by methotrexate. Injection will take away that problem usually. That's a very helpful way of giving it once a week, and that's the other important thing, that we can use methotrexate, or we use methotrexate only once a week. Along with that, one takes folic acid to reduce the side effects. And for the most part, it's well tolerated, right? Other drugs that came out as biologics in the first almost 15 years, until we had the introduction of Xeljanz, which is a tablet. We had mostly injectable drugs because these are protein molecules. These are not going to be taken by mouth because proteins are digested by the enzymes in the gut. So they have to be necessarily given as infusion or injections. So you have Enbrel injections that are taken self-injected. Most of these are self-injected. Infusions have to be given in a doctor's office. Mm-hmm. But both of them are safe. I mean, both modes of delivery. Not until about 5 years ago, when we had the benefit of Xeljanz introduced. That particular drug is a tablet. Completely different mechanism of action. I think we've had a lot of success with drugs like Xeljanz, Rinvoq, Olumiant. They're all in one class of drugs, but they're oral or tablet form. So there are options based on the patient's need and patient's response to the drug. Mm-hmm. The good thing is that if one drug does not work, we can safely go on to another drug.
Okay, great information.
And achieve what we are hoping for, which is remission.
Yeah. Let's switch gears a little bit. You mentioned another type of inflammatory arthritis, that's gout. So can you tell us a little bit about gout? What are the risk factors for getting gout, and how that can be treated?
Well, gout's one of these diseases that when it hurts you, you really cry like a baby. So it is something that will take you to the doctor or the emergency room right away because it is so unbearably painful disease. Fortunately, there are very good drugs, but it has to be, again, like with any disease, you have to take the right medications and be treated in the right manner to get over. So acute gout is when you have one joint, usually one or two joints at the most, and very often it picks the big toe or where the bunion joint is, or bunion deformities come about, the first or the great toe joint. When there is extreme amount of redness, pain, swelling, just overnight. You go to sleep feeling well. At 3 o'clock, you wake up to go to the restroom and you can't put your foot on the floor. You come to go to the doctor's office on crutches. So that's how bad and how dramatic the onset of gout is. That's acute gout, and it comes, and with or without treatment, it should get better in the early stages of the disease. It gets better on its own. You can take some Advil, Aleve, and 5 days later you're better and you think you're okay. Well, it comes again. So sometimes without treatment, you will go even months together and you might not need treatment. But if it keeps coming frequently, I think it is going to affect your quality of life, your work, everything gets messed up. So it is much better to treat it because it's one of the most treatable forms of the disease. And for the last, 60 years maybe, we have had allopurinol. It's even older than that, I think. Mm-hmm. So you can use a drug like allopurinol to reduce the uric acid. So what is gout? Uric acid is a waste product of nucleic acids. Nucleic acids are in excess amount and form crystals in the joint, and that leads to inflammation in the joints and pain, and therefore treatment with a drug like allopurinol and acute gout treatment with steroids is helpful and manageable, and people can live without pain from gout.
That's good. Dr. Joseph, we're already approaching the end of this episode. I can't imagine how quickly
30
time
minutes.
flew by. I think autoimmune rheumatologic diseases are fascinating, and I think people need to remember they're treatable. But for us, remember to check on Facebook, Instagram, Twitter, and our website, Doc Talk Live, to get more information about both this week's show and next week's new show. Dr. Joseph, is there any last minute information you'd like to share with our patients?
Well, I had wanted to say something about how to navigate the medical world, and maybe I would say if some of you in the audience or people who listen to the podcast have not heard about GoodRx, I'm not, I have nothing to do with the company, but they are an extremely used. That is an app that you can download, goodrx.com, and you can get the pricing of your prices of all your medications that you're looking at the best price in the right pharmacy, and have your doctors call it into the right pharmacy so that you can save a lot of money and also make it possible for especially chronic diseases like hypertension that you treat, so that you don't develop renal failure, diabetic medication. So it is extremely important to use that GoodRx app, and I think it is they advertise it a lot and you can see it, but I think it's a very useful and a very helpful way of getting access to drugs.
Wonderful. That's great advice. Thanks, everyone, for listening. This is Dr. Prakash signing off. Stay healthy, America.